thank you so much. I'm really pleased that I can talk about viruses and drug allergies and have a look at this with you. And when I talk about drug allergies, I will really focus on the type 4 reactions, so T-cell mediated reactions. And from the structure, we will first have a look a little bit more globally and talk about the concept, how this interplay between viruses and drug allergy could take place. And then I will focus more on COVID-19 and also our experiences that we did during these past years. So when I thought about this question, virus and drug allergies, and about the clinical experience, but also the literature in the end and studies that have been made, it came to me a little bit like a chicken or egg situation, because in other words, from the clinic, we know both situations. So patients who present with a viral infection, they first have a viral infection with fever, fatigue, and then secondarily, they develop a drug hypersensitivity reaction. But we also know the other way around. So in other words, quite severe drug hypersensitivity reactions, so quite extensive maculopapular exanthema, often, liver enzymes are rising, or we have even a DRESS. And secondarily, the patients developed a viremia or reactivation, especially of drug viruses. And we will go more into detail of these two situations, but what is really striking here is that the drug is not necessarily always present. Now, of course, when thinking of this situation, the question arises, how can a virus prime for T-cell mediated drug hypersensitivity reactions? How could this actually work? And here I refer to this PI concept from Werner Pichler. So you know that usually we need the two signals, co-stimulation and MHC TCR binding with the antigen. But in this PI concept stimulation, which normally would not necessarily provoke an activation of the T cell, this could actually change in the presence of a virus, because basically we might have an upregulation of MHC and also of the T cell receptor density on the cell. And on a clinical level, this would mean that in the situation of a low affinity reaction, we do not necessarily have a drug reactivity or only very mild exanthema. But when the virus is here, and in the secondarily also to the stimulation via cytokines, we have an increase of MHC TCR and thereby more PI interactions, which finally mediate this reaction or cause this reaction. Now, clinical examples for this concept are especially, which is especially seen in children very often, the viral infection, which make an exanthema, then they get antibiotics. But also adult patients can, of course, be affected. And what goes kind of hand in hand with this situation is, of course, the differential diagnosis challenge when we see such patients who also received an antibiotic, for instance, so to differentiate between the viral exanthema and a drug-induced reaction. And there has been a lot of research in this topic, so to identify either clinical factors or on a histological level to differentiate these situations. Also, people looked at eosinophilia or other serological markers, but so far without any major success to really keep these two apart, if it's possible, actually. So the other situation, which has been brought up very, very nicely, I think, this morning by Lukas Jörg, is in the case of EBV infection, so infectious mononucleosis, where we often see this ampicillin rash, but as Lukas pointed out, it can also occur with other antibiotics, and where in the end we only have about 10 to 30% of patients who actually react in the allergical workup later on. Although as Lucas pointed out, the importance to really still investigate these patients in the case of moderate to severe reactions. And as a quite particular situation, HIV patients, where we know from studies which mostly have been performed actually in the 90s, where we see an up to 100 times increased incidence of T-cell mediated drug hypersensitivity reactions such as Stevens-Johnson syndrome, and then to more specific reactions, for instance, sulfonamide exanthema. Of course, in HIV patients, the situation is even more complex because we have so many changes in the T-cell compartment. So there's Treg depletion, and then also the level of viremia, of course, plays a role, and the different very particular medications that they receive, so the NNRTIs, and also other anti-infectious agents. Now, the other situation, when we think about a drug hypersensitivity first, and then a viral reactivation of herpes viruses, for instance. So here we can think about the situation of DRESS, so where we have not only a skin-limited reaction, but really a systemic reaction, or a very extensive maculopapular exanthema, which might already swap towards a systemic level, where we have a drug-dependent expansion of T-cell, but with the massive activation, then we might also have an activation, concurrent activation of PI-activated cells, which then might react with viral peptides. And in the case of DRESS, this might manifest, for instance, with a clinical exacerbation or flare-up. And the particular thing about this is that this could come really much later into the reaction, where we do not necessarily have the causative drug in the system anymore. Now, this question whether it's really this way around in DRESS, so that we have first the development of the drug-specific response and then the viral reactivation, is still debated. As you can appreciate, for instance, already from the diagnostic criteria, which in the Japanese, according to the Japanese Society, even includes this HHV6 reactivation in the definition of a DRESS case. This is not the case, however, in the Regiscar European criteria. And I must say, from my experience, only a very, very minor fraction of the DRESS patients really had a viral reactivation. So I personally have not seen that frequently. Now, just to kind of sum this up for the relevance to the clinic of this. So we have seen the part that in DRESS that we might have a more severe course, or even these flare-up and relapses. Then what in terms of DRESS treatment, what is done in the case at least of very high CMV viral load in the blood is that patients are really treated with antiviral agents such as gencyclovir and valganciclovir, to the best of my knowledge, and maybe I'm curious what you think about it, I'm not aware of studies where it was addressed whether the viral reactivation in the acute phase would make an impact on the diagnostic workup later on, so after the reaction. And with this, although I'm sure that most of you or everybody wants not necessarily to talk about COVID-19 anymore, but I think it's a good time point that we look back on our experiences of the past 2 years. So we have very nicely heard about this part, reactions to SARS-CoV-2 vaccinations. Another area where this was kind of relevant were drug hypersensitivity reactions, which were reported against medications that were actually used to treat SARS-CoV-2. And there was a series of especially AGAPs, but also Stephen Johnson TEN, to agents like hydroxychloroquine that were used especially in the beginning of the pandemic in 2020. I will, however, focus more on this part here, so really the potential interplay between SARS-CoV-2 and drug hypersensitivity reactions. And there again, we have the question how and if COVID-19 may actually impact the course and development of DHR. And so from our own experience, so in Zurich, we saw a series of patients who were on the intensive care unit for a very severe course of COVID-19. They had been intubated for 2 to 3 weeks already, and then developed, as you can see here, macular or maculopapular exanthema. And when we talked about colleagues from Milano and also Paris, they actually saw similar cases. So this was quite in the beginning of the pandemic in 2020, and overall we had 18 cases like that. And when we kind of collected the clinical characteristics of these patients, what they all had in common was that they had a really very severe disease course of COVID-19. And at the time of the onset of what we thought was a drug reactions, the PCR was not positive anymore for SARS-CoV-2. They all presented with maculopapular or macular exanthema quite extensively on the body surface, and had a quite prominent eosinophilia, which seemed really particular. And the time of resolution was longer than what we would usually expect from benign maculopapular exanthema. Now, of course, this raised the question whether a severe course of COVID-19 might favor the development of these reactions, and whether the virus itself may impact it or if it's an indirect effect. So to address this, we collected, I call this COVID MDR cases, and as control groups we had DRESS and regular maculopapular drug reactions. We collected serum and skin biopsies of these patients, and I will not go into details about the experiments, but basically we looked at the cellular infiltrates in the skin. We looked on a molecular level and whether the virus was present there, and made a very broad inflammatory protein expression screening in the serum. Now, just to summarize what we found here was that what was particularly about this reaction was that we found highly cytotoxic CD8 positive T cells and a quite particular phenotype of hyperactivated macrophages in the skin, but we did not find any SARS-CoV-2 in the skin, which made us think that it's not a direct effect of the virus, who potentially could have acted as a danger signal, but an indirect effect. And this fitted with what we found on a systemic level, which was basically a massive cytokine storm and high eosinophilia. And we did not find this in other patients who were also on the ICU with a similar course of COVID-19, but not these drug reactions. And we did not find the similar, something similar in DRESS and regular MDRs. So of course we have talked about DRESS in more general. Now, what was it with DRESS in the COVID-19 patients? So here we had one case, for instance, on the intensive care unit in May, quite at the beginning of the pandemic, was a 54-year-old woman. She was already on the ICU also for quite a while, treated for severe COVID-19, and she developed maculopapular exanthema, lymphadenopathy, facial swelling, and fever. And as a potential causative drug, we identified here piperacillin. So she had eosinophilia, no atypical lymphocytes, And I will make it short, but basically we could confirm the diagnosis of ADR-AC and started with high-dose corticosteroids. But as you can see here, with the eosinophilia, she did not respond, and she did not respond, most importantly, on a clinical level. So based, and you might hear more about it later, based on also very high IL-5 that we found in the serum, and that IL-5 might be the main activator of eosinophils in this situation, we decided to give benralizumab, so an IL-5 receptor alpha antibody, and actually observed a quite nice clinical response and also immediate drop, of course, of the eosinophils. And when we looked on a molecular level, so using a high-throughput proteomics assay, what this does in the serum, we found not only downregulation of monocyte macrophage-related molecules in the serum, but also molecules related to the T-cell response, which might point towards a role of this agent in modulating the T-cell response in ADR-AC. So basically, what can we extrapolate from this? So in patients with a very severe COVID-19 disease course, it could be possible that the associated cytokine storm, even in the absence of the virus, might indirectly impact and favor the development of delay-type drug hypersensitivity reactions. And this might, even for ADR-AC, result in a more severe clinical course. And this is really speculation, but it might be possible that this could also impact the responsiveness to systemic glucocorticoids in these patients. So we had 3 more similar cases actually of ADR-AC like this. And of course, there are many more open questions that arise from this. Also, as you have seen, this was really, the cases were kind of concentrated in 2020, also a little bit 21. So it might also be a possibility that this is related to certain SARS-CoV-2 strains and not a global phenomenon. Yeah, we will see what comes next. So basically, there's much more we need to understand in more depth, I think, and we also need kind of truth-telling experiments to further explore this interplay between viruses and drug allergies. And with this, I would like to finish and thank you very much for your attention. And I would also, I'm sorry, the acknowledgement slide is not here, but I would really like to thank my team for the experimental work that I showed.
Thank you for this very interesting talk. Werner, a question?
Yes. Eosinophilia, in the cases without drug hypersensitivity, which you had some mentioned, some of them, did you find some eosinophilia in COVID alone?
As actually we found eosinophilia, but rather late in the course of the disease. So
but
what
moderate,
is actually
moderate.
Yeah, exactly, rather moderate. Eosinophilia. So yeah, I think it's very tempting to think that this, the eosinophils could make a difference here. I think that we need to probably look deeper into the phenotype also of these eosinophils. So actually we might, not have the same type, or they might not play the same role in just viral infection and then drug hypersensitivity. But it's a very good question, yeah.
No, because 30 years ago, we analyzed serum for IL-5 in normal viral infections, about 30 or 40 people, and drug hypersensitivity. And we found IL-5 and eosinophilia only in drug hypersensitivity.
I don't know about the IL-5 actually. That's a good, good question. But
one of the first.
yeah.
No, we mentioned that.
Okay. Thank you.
I believe that the eosinophilia, if you have an early onset of eosinophilia in this disease, it's most likely a sign of drug stimulation, not virus stimulation.
Might be, yeah.
Yes,
And
but it would be quite important to understand how to treat.
yeah, that's true. So what has been shown in very severely affected COVID-19 patients independently, yeah, as a risk factor for a severe course is actually eosinopenia. So if they don't have a lot of eosinophils, they seem to have a more severe disease course. But yeah.
Only a small remark to usage of antiviral drugs in the treatment of stress. I think one should stress that this is a very risky undertaking because we have seen in Inselspital, we lost patients because some infectiologists said, okay, this is too much of virus, added antiviral agents, and the transplanted liver got lost on this, again, stimulus, because you are very prone to get new and multiple drug hypersensitivities in this recovery phase. So actually our role should be to keep the infectiologist away from the bed and try to protect the patient.
No, it's a very good point. I must say, we never treated a patient with antiviral agents. This is so.
Supplementing this, because I had a discussion last virtual DRM with the Japanese. I just asked them if they see ever a drug hypersensitivity reaction to this ganglioside or the viral treatment, because they do it routinely and recommend officially to use CMV agents. And they told me, maybe spontaneously, because they didn't want, they say no, they didn't see any reaction. But I share your opinion that this is quite a risky undertaking, and sometimes to be modest and to not to do it, it's very difficult. It's very courageous of the doctors not to do something.
I have a practical question. Yes. So once this patient recuperates and is re-exposed to this antibiotic, the inciting agent, is there a persistent reaction to expect?
In which patients?
And the stress patient you had there, if is it a transitory phenomena, or is it something that persists after the patient overcomes the viral disease?
Well, I think nobody would dare to give it.
I know. I'm just asking. Is this a transitory, as we see with?
I think if it's a severe reaction, I will stay on for 20 days.
Okay. That's just from.
It's the same discussion as in the morning. If it's a severe reaction, you have to take it seriously.
Okay.
And we can analyze them.
Okay.
In vitro,
okay.
Analyze some of these patients for 12 years, 20 years.
And
Anna did some of these studies.
Okay. And the other thing is, you mentioned sort of immunological data to the effect that macrophage activation could be an issue, and we actually had to use IL-6 based treatments for macrophage activation syndromes in these patients that had tissue eosinophilia, but they had cleared the COVID, so with the severe pancytopenia. So I don't know if you're over-focusing on the eosinophilia and what's the epiphenomenon, you know what I mean? So
I think it's a very good point, and I think it's very complex because there are so many factors playing into that, and to really dissect, what's the role there and how this could play together is, I'm sure we're not really in depth yet. And so it's. Not hopefully not IL-6. No, but so it's really not clear. And also, I'm not so sure about the IL-5 because in the end, we don't really know how it might impact the antiviral immune response. So it's certainly something we need to explore more. Yeah.
I have a last question about hydroxychloroquine that was really highly used in the beginning of COVID. And we know that actually hypersensitivity, delayed type hypersensitivity to hydroxychloroquine can occur. It's rare, but we measure this sometimes in cyto-LTT. And I was surprised to see we didn't see any increase. Do you know if there is really publication about any possible increase of the rate of this? Because together with the infection, I would have expected more reaction.
So it's an interesting point. So, I mean, there has been really case series, especially from Italy, so more from the beginning, but not from Switzerland. I must say, I know
it
that
might
in
be
Lausanne
related to that,
used it
a lot.
But in even in the beginning in Zurich, it was also used, but I haven't seen personally a patient with that. And to the best of my knowledge, there are now really, studies on a bigger scale saying, what was really the incidence. I don't think this has been performed, but purely on the case series basis.
Yeah. Thank you.
Yeah.